let's just stop and talk about triplet therapy. How, who is the triplet therapy patient? We have the great data from Aerosonce, we have the great data from Piece 1 that showed a significant benefit. How do you decide, Rene, who gets triplet and who gets doublet?
Well, clearly, high volume metastatic disease. I think in that setting, most of the time I recommend triple therapy, especially a diffuse bone disease, more than lymph nodes, aggressive cancer. I think the majority of them is clearly you should start early. Of course, you have to have a relationship with your local oncologist, to assist with that. And it basically is what's best for the patient. But I think without question, the high volume, very aggressive, high risk patient. Then you get a little bit into that, okay, so what is high volume or medium volume? You have in the axial skeletons of metastases, you have a great group, say 3 or 4. The PSA is not terribly high. Again, you may assess response early on with imaging a few months, say 3-4 months after you start therapy, and then decide if the patient is responding well, you may hold off. But if it's not what you would like, then I think that's another situation where the chemo, Taxol-based chemo would be indicated.
No, that's good response. Josh, what do you think as far as triplet therapy? You're how many years out of fellowship?
4 years now.
4 years,
yeah.
so you're the young guy.
Looks like 6 months.
Yeah.
But, obviously you weren't trained in this field, but you've adapted to it and learned pretty quickly how to manage these patients. What do you think the role is for triplet therapy in advanced prostate cancer?
Yeah, I think to your point, like you were saying with Aerosonce and Piece 1 trial, there has been a significant benefit to these additional modalities with chemotherapy. The jury's still out in terms of overall survival with abiraterone, I believe, but it appears with darolutamide, it really has been shown to be beneficial to patients. Fairly well tolerated too, for the most part.
So knowing that the data is so strong,
yeah.
How do you decide who gets doublet versus who gets triplet?
Ideally, going again to the idea of high risk versus low risk, it's similar to what Rene was mentioning with metastatic disease outside the axial skeleton. I think clinical risk factors as well play a role. A patient who's African American, strong family history, that's also going to play a role into their risk nature. And then additionally, newer genetic testing, if they come in metastatic, germline testing obviously is highly beneficial, and somatic testing as well. Taking that into account will also provide an idea and an insight as to how aggressive this disease may or may not be. You got a patient who comes, whose father, grandfather, great-grandfather all passed from prostate cancer. You're going to treat them a little different than somebody who comes in as a de novo in the family, I think that plays a big role in it.
No, those are great points.
So I'm going to jump in only for a second because I don't think, just not to be contrarian, but if there's only a great clinical trial without docetaxel out there somewhere, maybe we'll talk about that soon. Because I think you can't overlook what docetaxel potentially can do to our patients, right?
True.
And that is really an interesting side effect profile. And it's most of the things that we give from an oral oncolytic standpoint, we kind of know what they're going to get if they're going to have a side effect and what that is. And docetaxel, is generally well tolerated, but we've had some guys have neuropathies and things like that. And it's kind of like once you buy that prize, it's yours to keep for a long time. So it is. I don't go down that road lightly, but I agree with everything that you guys have said about it. But I think it's definitely a cautionary to those patients with docetaxel.
So you're very selective.
Correct.
On triplet.
Yeah.
And who is your classic Aerosonce patient?
So again,
like when you look in, who's the guy who walks into your clinic, you're like, this guy's getting,
Yeah, I mean, younger guys and high volume. So I think that they could really tolerate that docetaxel component. We know, I think when we talk about Aeronote later, if you add, Daro, it's just the side effect profile is almost so low, you're not really putting them at risk for anything. So really the risk drives is driven from docetaxel. So to me, it's got to be somebody young, bad disease, really aggressive in their health as well. We try to get these guys exercising and taking control of their lives, again, just to try to get them through that, to tolerate that. So that's really my ideal patient.
So I'm going to get a little controversial here, put you guys on the spot. we talked about triplet therapy, which can be a challenge of who's the best candidate. But how do you decide which oral therapy? We have basically 4 options now: abiraterone, darolutamide, apalutamide, and enzalutamide. When there's 4 options of these therapies, how do you decide which is the best one? Do you have an algorithm or a process that goes through your head when you're deciding? I'll start with
The answer
you,
is
Rene.
no. My go-to first is Xtandi. I think the toxicity profile and the tolerability is favorable. I'm a little biased. My father was Xtandi, and he did very well. And I see it in my patients, I mean, abiraterone has more potential side effects, intolerability, hypertension, electrolytes, that sort of thing. It has to be taken with steroids. So, I mean, and between Xtandi and the other 2, I think it's a matter of personal preference. Tolerability with the APA.
So you're the urologist. You stick, you're very regimented. You stick with what you know and what you like. Josh, what about you? Do you?
I think this is
use
the
all
hardest.
4,
I do, and I find that this was the hardest challenge. Going back to what you were saying, learning this space. That's what I've had to wrestle with the most. I think of which one. I get patients that'll ask me straight up, why are we picking this one over the other? Where I try to begin with is side effect profile. So like someone who's an uncontrolled diabetic, abiraterone may not be a good option for them because of the prednisone. Or the obvious one, if a patient has a history of seizures or things like that, obviously enzalutamide's not going to work. But at the end of the day, to Ken's point, darolutamide really is coming out now with being the easiest to tolerate, and then also less interaction with other medications. Plus, you get the added benefit that if they are going to need to go on to triple therapy or triplet therapy, it's just an easy go-to for that. But in terms of these medications, another thing to keep in mind is the financial toxicity of them. And so a lot of the times I'll warn the patient, say, hey, listen, we'll start you on this medication. We have a wonderful back end that's going to look into the insurances. Coverage for these medications, and at the end of the day, that may drive which way we go with this, dependent upon how well your insurance company is going to cover this medication. Now, fortunately, most of them have gone, or 2 of them now are generic, which makes it a little easier on their pocketbook. But I think that's a huge driver in a lot of this space right now of what can the patient even afford to to
financial
do.
toxicity, payer coverage is critical.
Yeah.
These drugs are expensive but very powerful.
Yeah.
But if it's going to drain their bank account or they can't afford it, it's not worth it to many of these patients or their families. Ken, let me ask you the same question. When you're deciding between the 4 available agents, what's your mental algorithm that you're going through as you evaluate these patients?
Right. I would agree with both Rene and Josh. I think financial toxicity is critical. Early on, if I pick one drug and then we have our own in-house dispensing and they help us take care of that, if we just can't get it done or it's going to cost the patient a ton of money, and that's a consistent problem, then that's going to, I think, shift all of us away from whatever that drug is. Now, our girls are amazing upstairs, but it does still happen sometimes. Again, I think a preference for me is always going to be Daro just because the side effect profile is so low, but right now it's got a limited window and I have to use triplet therapy to do it. So I think that's one of the things that makes me think about it. Otherwise, I think a lot of us lean towards either APA or Enza as our first choice.